Okay, well, so I just want to do a quick run through of this paper right here. So, persistent SARS-CoV-2 RNA positivity in a patient for 92 days after disease onset. So, this is a nice short one because I'm feeling a little bit lazy. And so, keep in mind, this is a preprint, so it's not actually, it has not been peer reviewed yet. And so some of the issues right now is there's a lot of data that's being collected and analyzed, but there is a, a limit to how fast we can peer review all of these papers. So what I want to do is go over this one, and this is a case study of an individual in China who had been testing positively for the genetic material of SARS-CoV-2 for 92 days, which is a significant 3-month. It's a 3-month time frame. Okay, so what we know is that in bats, and we presume that this SARS-CoV-2 originated in bats, or at least has existed for a significant period of time, um, basically brewing and multiplying within bats as a species. Therefore, or what am I getting at? So we know that some bat coronaviruses can live happily in bats for at least 4 months. Now, normally that's associated with the hibernation phase of the bats, but either way, these viruses sometimes can find a way to exist with their host for a significant period of time. Okay, so you would hope that your immune system takes care of it and completely eliminates it from the body. Um, but we aren't sure for now. So, what I would like to do is go over this as basically as proof of concept. The concept being that these viruses can live inside your body for a significant period of time. So, with that, let's begin. The background. So, recently, patients with COVID-19 who showed persistently positive SARS-CoV-2 nucleic acid test results despite resolved clinical symptoms, so after the pathogenesis or after the pathology has already been, after they've already healed theoretically from their symptoms, um, they have attracted a lot of attention. We report the case of a patient with mild symptoms of coronavirus disease, so he never had severe symptoms. Um, and this person achieved clinical recovery but showed persistently positive SARS-CoV-2 nucleic acid tests until day 92 after disease onset. Okay. So even though he only had a mild illness, and even though he completely recovered, for some reason, the genetic material from the virus persisted in his body at concentrations that were still detectable. Anyways, case presentation. The patient is a 50-year-old man with mild symptoms of coronavirus disease. He was quarantined for 100. It's like a third of a year. Anyways, he was quarantined for 105 days, and of these, inpatient quarantine lasted for 75 days. When the nucleic acid test results were negative for 3 consecutive days, the patient was discharged at day 75 after disease onset. So he was basically in some sort of clinical care and forced to quarantine during that time, and he was there for 75 days. And then he tested negative for 3 consecutive days, and then they considered that sufficient to allow him to leave. Anyways, during this period, multiple samples were collected from the patient's body surface, the surrounding environment, and physical surfaces, but none of these tested positive for SARS-CoV-2. So this is very, very good to hear that even though he himself was testing positive, that the surrounding areas were testing negative. So this would indicate at least that he was no longer infectious, at least from that yeah, we would presume that he was no longer emitting significant amounts of viruses, or if in the off chance he was, they could have been coated with antibodies, which might have prevented them from moving around as well. Who knows exactly what happens. There's probably less virus concentration in his fluids. But granted, this doesn't say anything about uh, semen. So that is something that we probably should consider as well. Anyways, these samples included those from anal swabs, hands, inner surface of masks, cell phones, bed rails, floor and the bed, and toilet bowl surfaces. However, nucleic acid retest results on day 80 and day 92 after the disease onset were positive for SARS-CoV-2 nucleic acid. So the patient continued with quarantine and observation at home. After the test results on days 101 and 105 after disease onset were negative, quarantine was terminated at last. So they needed two consecutive negatives after that positive, and they got it. The two consecutive negatives are 101 and 105, and then they decided you can finally stop quarantining. Holy hell, that would be miserable. Anyways, their conclusion. Per our knowledge, this is the longest known time that a patient has tested positive for SARS-CoV-2 nucleic acid. So keep in mind, this is a case study, and they had their eye on this person explicitly because they got the positive test results periodically. So if you could imagine, there's probably plenty of people who would have tested positive, such as Sweden, and then they just hadn't decided. Maybe they got two negative tests in a row, and they said, "Okay, you're good," and then just let you go. But since they're in a more or what would the word be? If they were in a country that wasn't so hard pressed to be very diligent on testing, um, it could have been that we have plenty of other people that would fit the same case, except we're just not testing enough to discover these cases. Okay, so in no symptoms were observed during the follow-ups. During hospitalization, the SARS-CoV-2 nucleic acid positivity was not observed in samples from the body surface and surrounding environment, and no verified transmission event occurred during the quarantine at home. And after undergoing clinical recovery, a minority of patients with COVID-19 have shown long-term positive results for the presence of SARS-CoV-2 nucleic acid. So this isn't the only case. In China, they have definitely found other cases where people are testing positive far longer after their clinical symptoms have subsided. So this has provided new understanding and research directions for coronavirus infection. The long-term follow-up and quarantine measures have been employed for such patients. Further studies are required to analyze potential infectivity in such patients and determine whether more effective antiviral drugs or regimens to enable these patients to completely clear the viral infection should be researched. So perhaps in a subset of people who contract coronavirus, perhaps they hold on to the virus for long periods of time after they have been after they've recovered, and maybe they're maybe they are hardly infectious at all. But there is a difference between hardly infectious and not infectious, right? So let's say your chances of infecting someone else has gone from 90% all the way down to 2%. Well, then there's still that 2% chance, and given a large enough population, that 2% could be very significant. Okay. And, if those people, let's say this particular subset of people, are actually harboring the virus and they are infectious for the rest of their life, and I'm, using an extreme example right now, but if there is a subset of people that are possibly infectious for the rest of their life, it'd be pretty much impossible to stop the continuation of the pandemic. So hopefully that's not the case, right? Um, for instance, with HIV, if we hadn't gone to great lengths to stop HIV in its tracks, pretty much everyone in the world would have HIV by now. Well, yeah, pretty much everyone. So the only people who wouldn't have it would be people who had, found a partner and were completely monogamous for significant periods of times. But that is worldwide. That is a uh, worldwide. That's a minority. I believe that the average person has uh, about 7 uh, sexual partners over the course of their life. And granted, that I think that was data from decades ago. That number's probably significantly increased now. And I think that was information in the United States, which historically has been a more monogamous, uh, at least in their idealistic society, they tended to be a little bit more monogamous. Uh, whether or not if that's actually true or not, who knows? But what I do want to point out is that if a disease truly does stick with someone for a very long time, those diseases become harder and harder to prevent from infecting the whole world. So we will see if our efforts if our efforts truly are worth it and are able to stop this. So, for instance, like we did with HIV, we have prevented it from spreading um, with uncontrolled what would the word be, exponential growth or logistic growth. Anyways, we should continue because now I'm rambling. So, okay, the background: the rapid spread of SARS-CoV-2 um, has caused the World Health Organization to define coronavirus disease as a public health emergency of international concern. In the span of several months, the number of patients with COVID-19 in the world has reached 4.8 million. Well, I believe that is now at 7 million. Let me check right now. So today is June 9th, and according to Worldometer, we are at 7.3 million confirmed cases. So this is already almost double. And let's be clear, these people sent this in not too long ago. So yeah, we've almost become a little bit numb to how quickly that number is growing. But anyways, and has continued to increase. Recently, the appearance of asymptomatic patients with COVID-19 has attracted attention. There are 3 possible scenarios for patients who are asymptomatic but test positive for viral nucleic acid. The first scenario is that the patient is infected but without disease onset, so they're truly asymptomatic. In these patients, the SARS-CoV-2 nucleic acid test result is positive, showing that the patient is either in the incubation period or has latent infection or is a carrier. The second scenario is that the patient does not develop the disease, but laboratory test shows positivity for the SARS-CoV-2 antibody and negativity for the nucleic acid, suggesting the presence of subclinical infection. So they got infected, but it was subclinical, so they didn't have clinical outcomes. Or, yeah, that would be the word. And because of this, their body was able to ramp up the correct type of antibodies right away, and the body was able to get ahead of the virus infection, and then presumably would keep the virus concentrations low enough to not cause disease. And the third scenario is that the COVID-19 related symptoms have disappeared and the patient has entered the convalescent phase. But SARS-CoV-2 nucleic acid tests results are positive for a long period of time. So this is the third case, which is the case that this case study is referring to. Anyways, in this study, we report the case of a patient with COVID-19 who achieved clinical recovery but showed persistently positive results on the SARS-CoV-2 nucleic acid test for up to 92 days after the disease onset. We studied the combined long-term treatment and management practice of this patient to analyze the clinical characteristics, pathogenesis, response to antiviral treatment, and infectivity in this case. So here is the case presentation. The case is a 50-year-old man, so getting up there in age, who had symptoms of fever and dry cough for more than 1 month and was admitted to the, I apologize for the insensitivity, but I can't pronounce it, so the Huo Shenshan Hospital on March 11th, 2020. The patient developed low-grade fever without any obvious case on January 22nd, 2020. So he was one of the earlier people to undergo this. His peak temperature was 38.8 degrees Celsius, accompanied by mild cough. However, the patient was not tested for SARS-CoV-2 nucleic acids and was quarantined at home. Okay, so he was already showing the symptoms, but he wasn't even tested, so they just left him at home. During this period, he was treated with these, and I don't know exactly what they do, but they're just medications, and his elevated body temperature returned to normal. On February 7th, his wife developed COVID-19 and tested positive for SARS-CoV-2 nucleic acids, and after treatment and recovery, she tested negative for these nucleic acids. However, on February 15th, the patient who actually gave it to his wife, the patient tested positive for SARS-CoV-2 nucleic acid, and he was admitted to the cabin hospital for treatment. Up until March 11th, the patient still had mild cough and was admitted to the Huashen Hospital for further diagnosis. Oh, wow. And treatment. After the onset of disease, his mental state, sleep, and diet remained fair, and bowel movement and micturition were normal. I don't know what micturition means. 1 second. Okay. Micturition, so the action of urinating. So his urinating was normal. On admission, his temperature, pulse, respiration, and blood pressure were normal, and oxygen saturation in the absence of oxygen inhalation was 96%. So, yeah, pretty good. Cardiopulmonary examination results were normal. After admission, the patient was diagnosed with COVID-19, and then there was a period of time, and they might still be doing it, the Chinese government was suggesting traditional Chinese medicine, but I couldn't find what herbs they were using. So that would be interesting to know what herbs they were prescribing to patients, and then figuring out what active ingredient in those herbs they concluded might be beneficial for COVID-19. Anyway, so traditional Chinese medicine was used for antitussive and expectorant treatment. So expectorant, I think, is like spewing stuff out. Let's look this up. An antitussive, that might be to prevent or relieve a cough. So I think that might be where Robitussin gets its name. And then expectorant, I think that is to expel mucus. Yeah, so it's for coughing up mucus, to get rid of mucus. Anyways, and his dry cough gradually disappeared. So computed tomography, or CT scans, on March 11th showed the following imaging changes. So symmetrical bilateral chests, increased diffuse density shadows in both lungs, and fiber-like cords were seen. So the fiber-like cords, I guess, would probably be indicative of some sort of scarring. Granted, I'm not a doctor, so don't take this as gospel, right? So these increased diffuse density shadows, I believe those would be the ground glass opacities, except I can't tell you for a fact. A lot of people use different terminologies, it feels like. So on March 24th, his chest CT scans showed significant improved bilateral lung lesions. bullae formation on the right lower lung. So let's look what bullae is. Large, oh, oh, man, a large blister containing fluid. Sorry, that gives me the willies. So there's a blister basically in the right lower lung, and no other apparent abnormalities. So viral scans of the oxygen in the absence of oxygen inhalation was 99%, and that's normal, and no abnormalities were found on physical examination. However, even with the recovery, this patient's nasopharyngeal swab tests were persistently positive for SARS-CoV-2 nucleic acids. So during hospitalization, he was treated with drugs recommended by the Chinese guidelines. Oral imifenovir, recombinant human interferon nebulization, chloroquine phosphate, and intermittent convalescent plasma were used successively. So these are different drugs. Let's look at what imifenovir is and what it is used for, because this might be beneficial to know. So it's a general antiviral treatment for influenza. It's used in Russia and China. So that's interesting that it's specifically used in these countries. They must do a lot of research on it. So although some Russian studies have shown it to be effective, it is not approved for use in other countries. So that's probably why we're not using it here. So what is the mechanism of action? So it inhibits membrane fusion of the influenza virus, prevents the contact between the virus and the target host cells, fusion between the viral envelope and the cell membrane of the target cell is inhibited. This prevents viral entry into the target cell and therefore protects it from infection. So some evidence suggests that it is better with RNA viruses than DNA viruses. So that is interesting that Russia and China have approved the use of this drug, whereas a lot of other countries do not. So there's imifenovir, recombinant human interferon. Interferon, I think this is one of the cytokines, if I remember correctly. Let's look up human interferon just to make sure I know. So it's a group of signaling proteins made and released by host cells in response to the presence of several viruses. Okay, yeah, so that was right. It's one of the cytokines that are released as a result of viral infections. And so they were giving recombinant human interferon into the lungs to convince the lungs to attack or be attacked. I wouldn't know exactly why the doctors were prescribing this, but just know that that is what they were doing. And they are also prescribing chloroquine, chloroquine phosphate. No mention of zinc here, unfortunately, but maybe they did some as well. And intermittent convalescent plasma. So taking the plasma from people who had recovered from COVID-19 and were testing negative for, I'd presume would be testing negative for the virus, getting their plasma, which should be rich in their antibodies, and then giving that plasma to this person and trying to lower it. So that actually, that could probably screw up this data a little bit, right? If they're injecting plasma from other people into him, that might theoretically be causing more genetic material, but then you have the same problem if other people are testing negative in their plasma, then giving their negative plasma to this person, like if that would be interesting. So if they had enough to cause a positive test, then they themselves would also test positive. So and then it's you'd be having the same problem. Interesting. Anyways, after the patient consented to participation in the danoprevir and the ritonavir clinical trial, oral danoprevir and ritonavir were administered for 10 days, and subsequently the patient tested negative for SARS-CoV-2 nucleic acids in his nasopharyngeal swabs for 3 days. And after all of this, he was discharged at day 75 after disease onset. We recommended that a patient continue with quarantine and observation at home, as well as wearing masks and maintaining ventilation, which is good. Keep in a well-ventilated area with a lot of fresh air. The patient was advised to maintain social distancing, eat alone, and practice good hand hygiene. However, viral nucleic acid tests on day 5 after discharge and day 15 showed positive results. So they probably weren't giving him more convalescent plasma after he was discharged. So these positive tests were definitely just from the viruses that were within him. Anyways, after test results on days 101 and 105, after disease onset were negative and quarantine was terminated. So during hospitalization, we obtained samples from other bodily states and the surrounding environment and objects to test for viral nucleic acids. The results are shown on table 2. Sputum samples were collected 4 times and 3 of them tested positive. Stool samples were collected twice and 1 tested positive. Anal swabs and samples from the oral and nasal cavities were obtained 4 times and all tested negative. Additionally, all environmental samples were tested negative. While the stool and sputum tested positive, SARS-CoV-2 nucleic acids were not detected in the nasal and oral cavities, hands, and inner mask surface. The surrounding environment, including the table and the head of her bed. Oh, so this was a woman. And the head of her bed, pillows, bedside, ground surfaces, cell phone surfaces, and air filtration net in the room tested negative for SARS-CoV-2. So all these things around her tested negative, which is excellent. We like to hear that because that means that you're probably not infectious if we can't even test it. So here they are giving the days, and they did multiple tests. They were testing for, so here are the nucleic acid tests, and this would be a PCR test, and there are different PCR tests you can do. So you can do a PCR test. Whenever you do these PCR tests, you're not checking the entirety of the genetic material of the virus. You're only checking for a small portion of it and then multiplying that small portion over and over again. And so if that portion is present at all, or if the term would be if the primers are present, then that means you can duplicate the area in between those primers over and over again, and then you can see that in your test. So here they decided to do nucleic acid tests on it's the open reading frame AB, and just know that that'd be one of the proteins that the virus is able to produce, and they just tested that area to see if that genetic material was there. So that's one of the proteins, and then a different protein is the N, and it's also known as the nucleocapsid protein. And the nucleocapsid is one of the proteins that help form the outer membrane of the virus as it's being produced. Okay, it's one of the structural proteins. So, and that is a different. They were also testing for the nucleic acids that are within or that are associated with producing that nucleocapsid protein. Okay, so with a lot of these tests, we don't, there's a lot of DNA, so there are a lot of different things that you can test for. Okay, and here they have an antibody test as well. And so why would the antibody test be important? Well, they're testing for both IgMs, which are the more short-lived antibodies, and they have IgGs, which are a more longer-lived type of antibody. So they did that, and these are N antibodies. So these are antibodies that are specific to attack this N nucleocapsid protein. Because remember, the viruses have multiple different proteins on them, and the antibodies can be generated against different types of surface proteins of the virus. So the spike proteins are one of them, the nucleocapsid proteins are another, but for this antibody test, they decided to go with the nucleocapsid protein. And I would presume there's a possibility they chose the nucleocapsid protein because of its maybe because it mutates less and has there might be yeah, that might be the reason why, because it might be less likely to mutate as you are doing these tests. The spike protein is probably more prone to mutation because of how uh, exposed it is, and the especially the receptor binding domain of the spike protein tends to mute, or I should say, tends to be more variable in between species of the same, uh, or I should say, in between species of the same family of coronaviruses. Though the spike protein is generally a little bit more mutation prone, so perhaps using the N antibodies would be a better way to do it. Regardless, that's just what they did. So they didn't always do the test. So ND means that they did not test for it. So here's the date and the disease after onset. So remember this person did not get tested when they first started showing symptoms. In fact, they weren't tested until 25 days after they started showing symptoms. So here, both the ORF and the nucleocapsid genetic material was found in those swabs, and they did not do tests for antibodies yet. So here we're going down, and already at 50 days, still testing positive for both of the nucleic acids and the genetic material for the two different proteins. And then the antibodies, you can see she is generating antibodies, and I wouldn't be able to tell you what these units are, AUs per L, but just know it's just a concentration of antibody, and maybe antibody activity, but I would just say antibodies. So, and then here you can see on day 57, her short-term antibodies are already decreasing. Her long-term antibodies are increasing still. So these are going up, these are going down, and you would usually see that progression happening. Day 60, her short-term antibodies still going down, her long-term antibodies are going up more, and she's still testing positive. And then let's go down here to day 71. So in day 71, she's only testing positive for the ORF AB, 1AB protein genetic material. But here you can see that both and she tested negative for the nucleocapsid protein genetic material. But you can see here her antibody concentrations are already going down. They're already decreasing. Okay, so this could be a positive sign if because theoretically it would mean that you are fully recovering, and now your antibodies, your immune cells are no longer running into new virus particles, and therefore they are ramping down their activity of creating new antibodies. That would possibly be a good sign. Anyways, continuing. So, and then day 72 still tests positive. Her antibody concentrations are going down for the IgMs, and ticked back up for the IgGs. But here she has 1, 2, 3 negative tests simultaneously, and this is when she is released home. So discharged, continue with quarantine and observation at home. So negative, 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 and they stopped doing the antibody test. So I wish that they would have kept these up, because that would have been good information to have. But they decided to just go with the genetic material tests. And here, at 82 days after disease onset, she tested positive for both of them. And I do like this, that they're using multiple PCRs for one test, because that could tell if one is positive and the other is negative, then you could very easily how do I phrase that? If they both agree with each other, that would indicate to you that that test was good. So the fact that you have both of them test positive at the same time, That is, they're both verifying each other, and that can give you a little bit more confidence in whether or not it was a false positive or not. And so it appears as though it's not a false positive. So that happens at 82 days, and then at 92 days, she tested positive again for both of them, which would be a pain. That would be a pain, right? So, but at the end, she ended up testing negative twice, and her quarantine was terminated. So, and here are the results of the nucleic acid testing on the clinical and environmental samples. So here you can see that in the sputum, 3 out of 4 were positive, and then in the stool, 1 out of 2 was positive. But for all of the environmental samples, they were all negative. So that's great. So the discussion and the conclusion. So recently, recently, patients with COVID-19 who showed persistently positive SARS-CoV-2 nucleic acid test results, despite resolved clinical symptoms, have attracted a lot of attention. So these people reported one patient who had persistently positive SARS-CoV-2 nucleic acid test results until day 49 after disease onset. In our study, we have reported a patient who achieved clinical recovery but showed persistently positive SARS-CoV-2 nucleic acid test results until day 92 after disease onset, which is currently the longest reported period for positive SARS-CoV-2 nucleic acid test results. The pathogenesis of the phenomenon is unclear, and the implications of these patients being potential sources of infection require further confirmation. So since they were sampling the environment, we would hope, and all those samples of the environment were negative, we would hope that this person would not be contagious. That would be the goal. But you can imagine there might be situations where this person could be positive. So if for any reason she wanted to donate blood, that might have been a possible source of transmission. If she went to the bars and they're in their 50s, so not very likely. But if they happen to go out to a crowded area and decide to partake in intimacy, then that could possibly be another route of transmission where normally there wouldn't be a transmission, but if you get into really close contact with multiple people, that transmission might become more likely. So that is something that needs to be studied, especially since there's a lot of people that tested negative and then they decided not to be tested ever again after that. So if this person might only be considered a special case, 92 days, she might be considered a special case just because she was monitored. But that doesn't mean that in the rest of the world, there's probably a lot of people exactly like this who think that they recovered completely, but they think they're recovered because they haven't been tested over and over again, right? So this is something that really needs to be considered. It really does. So it may also be pertinent to further examine the subsequent management and treatment of such patients. A study using ultra-deep sequencing of 11 patient-derived virus isolates showed that there are 33 mutations in SARS-CoV-2, of which 19 are novel mutations. And among these patients, patient number 11 showed persistent positivity for viral nucleic acids for 45 days, and 3 nucleotide mutations were found in this particular virus isolate. So subsequent experiments analyzed the replication speed and pathogenicity and suggested that persistent nucleic acid positivity may be associated with virus mutations. So there's a small chance that we know that this virus doesn't mutate too frequently, but it doesn't. At some point, it doesn't matter if it's mutating a lot. It just requires a few mutations, possibly, to go from being from having one particular phenotype or one particular set of characteristics. It might only take a few mutations to evolve completely different phenotypes or characteristics, and that can cause a significantly different impact or outcome on the patient's clinical outcome, possibly. So those mutations that these people are referencing might have that correlation, but we would just need more data to have a better idea of what is going on. Anyways, another study reported a patient with COVID-19 who died due to stroke, and the nasopharyngeal swab samples from that patient tested negative for SARS-CoV-2 in 3 continuous polymerase chain reaction tests. So here, we're seeing that even, this is something also of concern too. So this person died due to a stroke, and it was presumably COVID-19 related. They're not, the fact that they're saying that it's COVID-19 leads me to believe that they were rigorous in their diagnosis. Anyways, this person died due to stroke that was the result of COVID-19, and even then, he was testing negative. So perhaps the virus is getting into low enough concentrations, but not completely disappearing, which would allow the resurgence of the virus to happen periodically. This is one of the reasons why I wish that they continued with the antibody studies on the antibody concentration studies on this particular case study, so that we can see if those are also going up and down as the virus concentrations are going up and down. You can always criticize a study, right? Anyways, however, electron microscopic and immunohistochemical staining images showed the presence of residual SARS-CoV-2 in the patient's lungs. Well, this is interesting. So what I would say here is that I wish that they would put whether or not these were full viruses that were visible. I guess that would be difficult to determine. Well, it wouldn't be too difficult. So immunohistochemical staining, that is when you are using antibodies engineered with fluorescent dyes on them in order to visualize a particular protein or peptide within a cell on a microscope. Because remember, these things are so small that you can't really use normal microscopy to find them. So you actually have to stain them with antibodies, and you can use fluorescent probes, and you can shine the light on the fluorescent probes to shine back light at you. And that shining back can be measured by a microscope. So that's what the immunohistochemical staining is. And so this shows the presence of residual SARS-CoV-2 in the patient's lungs. So even if he's testing negative for the genetic material, they can still see the proteins. Now, are these just dead proteins, residual proteins, or is it truly that the viruses are still multiplying in the lungs, just at concentrations that are too low to detect? I wish that they would have presented that here. Now, what I would presume is that if the viruses were in fact fully viable and functioning, then you would see a lot more specks of this staining. So this immunohistochemical staining. Actually, I'll get a photo so that y'all can be aware. So this would be an example of the target antigen detecting method. So you put on an antibody, the antibody connects to the protein you want to look at, and then you sometimes can put another. These are two different types. So this one, you have an antibody, and the antibody has the fluorescent tag on it. And if it binds to that protein, then you can say, yes, the protein is here. And then the other way to do it is you have one antibody, and then you add another antibody with a fluorescent probe on it. Now, I'm trying to find a photo. So yeah, here's a photo of one type of immunofluorescent staining, of some immunofluorescent staining that's going on. And here's another one. So one could say, let's say your stain was green and you were looking for the virus protein particles. So if the viruses were whole, as they are being generated in the, say, endoplasmic reticulum, or they wouldn't necessarily need to be inside of the cell, they could be outside of the cell in their full-fledged virus forms, they would probably be seen as more as dots, if that makes sense. So there'd be dots of um, these viruses. However, if it was just the useless protein that was left behind, then it'd probably be more of a cloud. Rather than having the proteins be all together with a bunch of the fluorescent around that one virus particle with all the proteins on the surface, if the proteins were all strewn about, we would probably see a fuzzier distribution of the fluorescent probe. However, all that is fine tuning of your parameters. So I don't know exactly uh, what conclusion they made with this particular paper, the paper that they're referencing. However, images showed the presence of the residual SARS-CoV-2 in the patient's lung, and this study provided a new understanding of SARS-CoV-2 infection. So the patient in our study tested negative for viral nucleic acid thrice in a row, but tested positive during follow-up. This shows that even two consecutively negative results on nucleic acid tests cannot be used as a marker of in vivo viral clearance. So this is one of the downsides when we were marking people as recovered from this virus. At the beginning, the recommendation was they need two consecutive negative tests. Two consecutive negative tests, and the loss of clinical symptoms was sufficient to call someone recovered. Okay? But what they are saying here is that that might not necessarily be a sufficient enough definition. Now, granted, if someone has gotten over the hump, if you will, if they have survived past the clinical symptoms, we would hope that after that there is no longer an increase in death. That you might still be positive, but your chances of dying are no longer above normal. You could still die in a car accident, right? Or you could still die from any other disease, but we would or hope that the presence of this virus after your clinical symptoms have gone away, we would hope that your chances of dying have gone back to baseline, that you are no longer more likely to die. However, this is something that needs to be considered as well, is if you have the virus, and maybe let's say it's in low concentrations for a significant period of time, what happens is that your new pre-existing condition. So when it comes to a lot of diseases, we talk about pre-existing conditions a lot because frequently comorbidities play a role in killing you. So it's rarely ever just one thing that kills you. Normally it's a combination of different factors that ends up resulting in your body no longer being able to repair itself faster than it's being damaged. So you die. Now, what happens if someone has the virus or coronavirus, SARS-CoV-2, living in them for 3 months? Are those 3 months of being at baseline no more risk of dying than normal, or is that 3 months of slightly higher risk? So is it if someone ends up, let's say someone overdoses on a drug now, but normally they would recover just fine. Well, what if they had coronavirus in them and they overdose, and rather than recovering, that ended up killing them? The combination of having coronavirus and overdosing ends up causing their death. That would be a shame, because then you lost the opportunity of recovery and you've lost the opportunity of rehabilitation. So really, that you could argue that coronavirus has taken a life before its time, and everyone could just argue left and right saying that person overdosed, they deserve to die, or they were asking for it. But that's not the way that we should look at it. We should look at it as that was a life that was taken before its time, because without coronavirus, we could have saved that person, and there was still the possibility of rehabilitation and to live a happy, healthier life after the fact. Okay, so it's never just these people had their pre-existing conditions, or these people were making their choices, and those increase the risk, and therefore, when they have to, pay up, for lack of a better term, if they get pushed over the edge and die, then that was their choice, and that should not be the mentality. That should not be the mentality. The mentality um, should be is you want, if people are making those choices and are increasing the risks, we want to decrease the risk everywhere else, wherever we can, because we want there to be the option of recovery and rehabilitation. We always want to keep that option open as long as possible for people. And if something like coronavirus, let's say it lives in your body for 3 months and then it pushes more people over the edge than normal, that would be a loss to humanity. Okay. Continuing, this new data shows the possibility that infection may persist, may persist after clinical recovery in COVID-19 and even evolve into chronic infection. So this is another thing that I am concerned about. I'm concerned for multiple reasons, but one reason is let's go back to the antibodies. So if the viruses are finding ways to modulate your metabolism with their viral proteins, even if you have overcome the severe clinical symptoms, if you still have these virus particles that are floating around, that are influencing your immunity, that are influencing the antibodies that you produce, that could have some negative consequences to your body, especially if there are autoimmune diseases that might result from the presence of these viral particles. If there are hormonal modulations that are the result of these viral particles, all of that can play a role in holistically affecting your health long term. And the worry would be, if these are chronic infections, then there might be more humps later on that you have to deal with. And if you're, we're still, what would the word be? There's still a lot of unknowns, but let's say there is a higher risk of long-term hormonal changes that happen in someone's body after contracting this particular coronavirus. Well, that is going to alter their phenotype. That is going to alter the way that their body naturally develops. Okay, so we could view this as viruses can play a role at changing phenotype of the species they infect. So for instance, I believe it's some tulips, some variegated tulips, will have stripes on them, and those stripes are the result of a viral infection. Now, if all tulips had those stripes, we would say, well, this is just a part of their natural phenotype. This is naturally how tulips are. And then when we look into it, we see, oh, these viruses are actually causing the stripes on these tulips. Well, then what is natural? What is the natural state of tulips? Well, we would say the natural state is without the virus, and really tulips are supposed to not have stripes. That would be the rationale. But if the virus was omnipresent among, or if it was ubiquitous among all tulips, we would just say that's the way things are. This is natural. So, one of my fears as well is, what is going to be the new natural of humankind if too many people end up contracting this virus and we decide to just let it take over everything? because I mean there are other viruses that do the same things. For instance, the other 4 human coronaviruses, we all get infected with those 4 over and over again. So you can get infected with the same species of coronavirus over again. So that that is permanently altering uh, human phenotype. Granted, we would hope that the alterations are not severe or nor significant. We don't know if this is the case with SARS-CoV-2 yet. And probably for how long it persists in the body, that and how recently it has crossed over from animals, specifically how recently it crossed over from bats, would indicate to me that its effects on long-term phenotype expression is probably going to be significant. Now, that's just my rationale uh, speaking, but hopefully that is proven wrong, and hopefully there's a complete recovery and all's well that ends well. But that cannot be ruled off the table yet. Anyways, rambling. Anyways, peripheral blood lymphocytopenia. So this is having lymphocytes or high levels of lymphocytes in the blood, is common in patients with COVID-19, and their autopsies show lymph nodal and spleen damage. So the lymphocytes are the white blood cells that predominantly are in the lymph nodes and the spleen. And since they are upregulated, there's a lot more of them than normally. And this is suggesting that the immune system damage may be a mechanism of persistent infection. So I like how they worded this. So, in bats, the spleen and the bone marrow of the bats, which are locations of the bone marrow, is where a lot of white blood cells go through their maturation process. They have a unique the ratio of their white blood cells that are distinct from other mammals. And so their ratio of white blood cells is indicative of persistent viral infection or an autoimmune disease, but without any clinical symptoms. The same goes with there's a similar story with their spleen, where the spleen always seems to be at least there are signatures that the spleen is always in an inflamed state or in an autoimmune state. So perhaps, and I should also mention the spleen is a part of the lymphatic system. So you can imagine the spleen is basically a very large lymph node that filters out the blood as well. So what does this tell me? That the autopsies show lymph nodal and spleen damage. That to me is indicative of the viruses are going into the lymph nodes in the spleen, and they are utilizing those areas to basically they're re-emulating, they're trying to live in the human body the same way that these viruses live in the spleens and lymph nodes of bats. But in bats, the bats have co-evolved, or at least have a lot of mechanisms that are in place that prevent the pathogenesis from these viruses. So they can harbor these viruses and not experience any of the symptoms, and they're fine. They live. They're great. They're happy. And these viruses are aware of this mutually beneficial. I shouldn't say mutually beneficial, but mutualism, and they live in the bats sometimes for months and are a-okay. When I see the damage done to the lymph nodes and the spleen damage, this is indicating to me that the viruses are trying to do in humans what they do in bats, but the human body fails at that, at least at a much higher percentage. The failure rate is much higher. And so we're seeing more lymph damage, we're seeing more spleen damage, and it should also be noted the spleen doesn't, in of itself, that I could find at the time, the spleen doesn't have a cell type that is ACE2 positive. So but there are lymphocytes. Some lymphocytes actually are ACE2 positive. So there probably is a mechanism by which these coronaviruses that utilize the ACE2 receptor, they might be utilizing infecting the white blood cells, and specifically the lymphocytes. So this is something that is of concern, especially if the viruses are living in your lymphatic system for long periods of time, even after you have recovered. Um, that raises some questions and concerns about what are the long-term immunological health effects of that. So let's continue. There was no significant correlation between the in vivo SARS-CoV-2 nucleocapsid protein antibody changes and the nucleic acid test results seen in that patient. So this may be because the N antibodies are not neutralizing antibodies. Well, that would make sense. I don't believe the nucleocapsid protein is nearly as exposed as, say, the spike protein. So, the way that you make a lot of antibodies um, isn't through just the exposed areas of a virus. So a lot of the unexposed uh, amino acid sequences of viruses can actually be used to produce antibodies, but those antibodies may be useless because the area that they're trying to attack is protected by the other structures of the virus. Um, so they're saying here that there was no correlation between antibody concentrations for the nucleocapsid protein versus the PCR tests. So you would hope that as the antibodies went up, that you would then very quickly see a drop off in the genetic material of the virus. But here they're saying that there's no correlation. So uh, regrettably, and I would say, well, let's not use the nucleocapsid protein. Let's use the spike protein, which is probably more likely to be neutralizing or at least subneutralizing. Well, here, regrettably, S antibody was not monitored at that time due to limitations. So keep in mind, this is back in January, so there was a lot of it was bad. So there was a lot of mistakes that were made just because of how serious of a situation it was. So regrettably, they probably didn't even think to look for S antibodies during this time frame. Regardless, in addition, the interplay between the virus and immune system may lead to immune evasion or induced immune tolerance, which this is scaring the hell out of me, where sometimes viruses find extremely effective ways at evading the immune system by generating tolerance or immunotolerance. And so these people are raising the concern that immunotolerance is being generated in these people, which would thereby mean that there is a long-term infection for every person that's getting, or at least a big portion of the people that are getting infected. Which means there might be long-term chronic illness associated with this virus that we have no idea about yet. So you can think of it like think of syphilis, right? So syphilis can exist in the system for long periods of time, and it can cause progressive damage to neurons and your nervous system. So if you get it treated right away, if you are able to get rid of the syphilis right away, you can avoid a lot of those chronic illnesses. But if you don't, you could have paralysis. You can have, well, wait, I take that back. I don't remember if you can get paralysis, but you can suffer some serious nerve damage from that. So this is a long-term consequence that we might have to we might be seeing very shortly. Anyways, between the virus and the immune system, the interplay between the virus and immune system may lead to immune evasion or induced immune tolerance, which may need to be analyzed in future in-depth studies. These patients do not require long-term inpatient quarantine for their post-discharge management, as their infectivity is low, which is good to think about. Hence, it is recommended that they should quarantine at home for an extended period and undergo periodic SARS-CoV-2 nucleic acid tests and should be observed for adverse outcomes due to the persistent viral infection. There is still a lot of debate on whether these patients are infectious and their infectivity. Positive viral nucleic acid test results show remaining viral genetic activity in this patient, and there have been reports of infectious viruses isolated from patient samples. So that is bad news. Where some people have discovered that some people are still producing infectious virus particles. So it's not just the genes that they're finding; they might be finding intact infectious viruses as well. Anyways, however, there has been no prior report suggesting that convalescent patients who test persistently positive for viral nucleic acids may infect others or cause local outbreaks. However, there has been no prior report suggesting that convalescent. Oh, yeah, I'm confusing it with the antibodies. So yeah, the recovered patients. There is no report suggesting that they are a large contributor to new viral infections. Uh, However, I don't think we have tested sexual transmission as well of convalescent patients. So that is something that also needs to be considered. Anyways, a recent study of 262 recovered patients found that there were 38 patients who tested positive for nucleic acids after recovery, but 21 close contacts of these patients tested negative, suggesting that they were not infected. And a possible explanation is that such patients are often quarantined in hospitals and individual and social preventative measures are adopted, which causes disease transmission to be lower. So this is one way that it'd be a non-pharmaceutical intervention. If you know someone around you that is tested positive or hospitalized, you might alter your behavior to lower the chances of getting infected yourself. Conversely, in the case of our patient, although viral nucleic acid test results from sputum samples were positive on March 17th and 24, but his nasal and oral cavities, hands, and inner surface of mask all tested negative. So this is good. Like, even though this person is testing positive, the other, like, even the face mask is testing negative, which is very good to hear. That means the virus concentrations are probably really, really low, and they're just barely detectable by the PCR. Anyways, his personal belongings and objects in his surrounding environment, including his cell phone, bed rail, floors, and toilet bowls surfaces, too tested negative, showing that the surrounding environment was not contaminated with the virus. This may be because this patient did not cough, expectorate, or show other behavior that could expel the virus from the respiratory tract, suggesting low possibility of infection. And another thing is perhaps this person was isolated at home, and so if you talking and singing might be a big way that you can get a lot of virus particles out into the environment. Well, if you're alone, you probably don't talk nearly as much, so that might be a good way to prevent the transmission of the virus. Anyways, and I should also mention that with all of the demonstrations that are going on in the United States, there is a lot of yelling, chanting, singing, large crowds, and not everyone's wearing a face mask. And so I do have some concerns about the demonstrations right now in the United States. So let's hope that nothing serious comes out of those. Anyways, as the prognosis of infectivity of patients with such persistent infection are unknown, it remains debatable whether an active search for effective antiviral treatments for such patients should be conducted. Currently, there are no drugs against SARS-CoV-2 that have proven effective in clinical trials. And although remdesivir is considered the most promising antiviral drug, the local and overseas clinical trials have seen inconsistent results. So yeah, it's a crapshoot right now trying to get good clinical trials on any drug, really. This may be due to differences in selected timing for antiviral treatment. So timing is everything for the drug. So if the drug has a particular mechanism of action that is time dependent, then if it is administered at the wrong time, then you might not see any benefit at all. Anyways, the number of patients and treatment endpoints. Our patient successfully received different antiviral treatments as recommended in the Chinese guidelines, such as the interferon nebulization, umifenavir, chloroquine phosphate, and convalescent phase plasma, but did not show persistent and stable negative nucleic acid test results. So even with all of these things that they attempted, it didn't stop the nucleic acid test from being positive, which is unfortunate. So after he was hospitalized, he was treated with danoprevir and its booster ritonavir for 10 days, and subsequently the patient tested negative for nucleic acid for 3 consecutive days. However, his nucleic acid test result was positive on day 92 after discharge, showing that the aforementioned antiviral regimen did not have significant effects on the negative conversion of nucleic acid test results. Thus, we should be vigilant for patients that may have chronic SARS-CoV-2 infection, and these patients should be closely followed up for a long period of time. Are we doing that in the United States? No, we're not. We're not doing that. So it's hard enough getting one PCR test done. So, God. Yeah, so to get follow-up PCR tests, yeah. Oh, God. We're screwed. Anyways, in conclusion, after patients with COVID-19 have achieved clinical recovery, a minority of patients may show positive SARS-CoV-2 nucleic acid test results for a long period of time. This provides new directions for research on SARS-CoV-2 infection. Further studies are required to understand the pathogenesis of this phenomenon and its implications in disease transmission. Such patients require long-term follow-up to observe potential long-term adverse outcomes. So remember, it's not just surviving that you have to worry about. It is, are there long-term clinical outcomes, especially for a disease that you can hold on to for 92 days, even after no longer having symptoms. That is something that really needs to be considered. Anyways, and they should be quarantined. Additionally, further studies are also required to analyze potential infectivity in such cases and determine whether a search for more effective antiviral drugs or regimens that completely clear the virus is warranted. So let's say, what if we do end up discovering that everyone who gets infected with this virus will forever have low levels of the virus in their system? Well, then this would have us shift gears, if you will, into antiviral drugs, saying, well, we need to get rid of this. We need to get rid of it. So we should start developing treatments to get rid of the virus or keep the virus concentrations as low as possible. So for instance, with HIV, that is a long-term chronic disease that can cause long-term chronic illness. So now we have done the research into a laundry list of drugs that can help control the progression of HIV into AIDS, and then it is also there to control the duplication of HIV. So even though it is there, you're keeping it at concentrations that are so low that you are basically living a completely normal life. Okay, so with that known, we might look into a similar vein of research for SARS-CoV-2 coronavirus, if it does end up staying with people for long periods of time. And also, it's not just the case where if you have the virus, if the virus stays in your body for a long time, it might be the case that having the virus in you for 3 months is associated with long-term health consequences. So what we might want to do is, rather than have you go through those 3 months of having the virus in you, what if we develop treatments that stop it after 1 month? And if that is effective, then you might be able to avoid long-term health consequences that we have yet to even discover. Okay, so um, what else do I want to mention? Um, I do want to bring some attention. So remember, the lymphocytes seem to be implicated in damage and being infected. So let's see. I believe the lymph system does end up connecting with the testicles. So lymphatic system in testicles. So the testis has collateral blood supply from this, and so lymphatic drainage of the testes follows the testicular arteries back to the para-aortic lymph nodes, where lymph from the scrotum drains into the inguinal lymph nodes. So, granted, I believe all parts of the body are connected to some part of the lymphatic system, so that wasn't really saying much. But, I have a concern now. If the lymph system is getting infected, then everything the lymph system connects to, including the testicles, which is, as we know, an immunoprivileged site, um, I can definitely see some long-term health consequences and reproductive ability consequences. Maybe not in everyone, but maybe in a large subset of people, and that would be a loss for those people who are just unlucky enough to have longer-term health consequences. So, anyways, with that, I think I'm going to close up. So if you have any corrections, questions, or suggestions on what I need to talk about next, you can leave them down into the comments below, and I read all of them, including that one spam. Uh, there's one spam account that keeps on saying "want to be friends" over and over again in all my videos. But I read those too. I read the spam, but I don't know. It's endearing. Um, God. So thank you for listening, and hopefully I will see you tomorrow.